Hi, I'm Betty Lynn Fisher, consumer columnist and medical reporter with the Akron Beacon Journal and Ohio.com. I am joined here today with University Hospital's cardiologist, Dr. Emil Hayek. Thank you very much for joining us today. Dr. Hayek and I worked together on the latest Healthy Actions column, which was in Saturday's paper. I won't go through the whole thing again, but you can read that at www.ohio.com/topics/Betty. And there are links to a year and a half worth of different Healthy Actions topics on a variety of topics where we talk to a wealth of experts that we have here in our medical community. So Dr. Hayek and I talked about heart health and in general, talking about things that shouldn't be surprising to anybody. Eat well, exercise, try to behave yourself as well as you can. But you talked about a little bit about how the diet itself has really just changed so much in recent years. But in general, and tell me if I've got this right, try to eat your lean meats, and or you were saying that, the healthiest patients you see are the vegans and the vegetarians.
Yes, no, I think it's the food pyramids that have been put out have kind of evolved over time, and I think one of the probable mistakes in recommendations in the past that we kind of learned the hard way was people would be told avoid fats, and it is good to avoid saturated fats, foods that are very high in saturated fats, but the problem is people would go low fat and then they would go high carb. And particularly simple carbohydrates, processed foods, things that are sugary or will turn into sugar, can be just as bad for you as the fats. So you're kind of trading one problem for another. We already have an epidemic of diabetes and heart disease, so that didn't necessarily help. So yeah, at the one extreme, going on a plant-based diet is certainly going to be the healthiest for your heart. But the vast majority of Americans are not going to take on a plant-based diet. So as you pointed out, fruits, vegetables, whole grains, and healthier choices of protein.
Okay. And then I wanted to talk a little bit more in depth about the calcium, coronary artery calcium screening. This is a relatively, actually I think it's a relatively new screening, right? And what's interesting about UH is that most insurances, even though it's a screening that could help you, most insurances aren't covering it like a mammogram or like a colonoscopy. And so Cleveland Clinic Akron General charges $100 out of pocket. Summa charges $199, but the University Hospitals is offering it for free to the community, and regardless of whether or not your primary care physician or you are a patient of UH.
That's right. So
okay.
This is because it's really an important screening test. It's no less important than some of the other screening tests that you mentioned, and there's a wealth of scientific information that really verifies that this test can make a difference in terms of estimating one's risk and potentially steering towards either medications or lifestyle adjustments. So it's just one of these preventative tests that have not yet been adopted by insurance companies. And so ever since coronary calcium scoring has been done, it's always been an out-of-pocket cash expense.
Okay. And this is, again, the screening is in conjunction with your primary care physician or your cardiologist, who obviously I'm sure is testing your blood, testing your cholesterol levels, watching your LDLs. Let's talk a little bit about who the recommended patients are that should undergo the screening.
So, and I think that's why it's important to discuss with, your own physician or practitioner is, should you be screened? Because there's clearly, a population who is at risk, who also is at an age where we can do something and change things. So generally speaking, men over 45, women over 55 with risk factors, whether it be high cholesterol, diabetes, smoking, high blood pressure, obesity, or genetic risk in the family. So if there's risk factors and you're in that age group, so those are the kind of the young age cut. As one gets older, the benefit of doing any screening test goes down.
Sure.
But certainly, I don't believe that there's one set age where we say, okay, we shouldn't screen that person. But for instance, I got a call yesterday about at 86 years old, should I do a coronary calcium scan? Probably not going to be helpful. because at 86, if finding out if there's plaque there's going to be plaque if one lives to that age. But the chances that in that individual we're going to do something differently is going to be pretty small.
Right.
Patients that have known heart disease already. So if you've already had a heart attack and you've got stents in your heart or you've had bypass surgery, then there's no point in screening. We already know
Sure.
you're going to have a very high calcium score.
Okay. And again, what this is, well, first of all, I want to back up, and I think we did mention this in the story. You said 45 for men, 55 for women, because women tend to show signs of coronary issues later than men?
Yeah, they seem to develop coronary heart disease about a decade later.
Okay.
So when you look at the American Heart Association guidelines for what constitutes a risk factor, there's still a gender difference by about a decade in terms of when we consider it either a risk factor for you or considered a family history risk factor for genetics. So, and that it does appear to be, no one knows for sure why it's later, whether it's estrogen protective effects on women that men don't have, or there's other factors we really don't understand. The concerning thing is that women will catch up. And so this is not to say that women are still not dying of heart disease more than any other problem. It's just it may start later.
Right, right. And okay, and again, the screening itself is an X-ray, and it is checking for calcified plaque within the arteries.
Yes.
Right, which then gives you, there's a score range that then tells you the higher the score, the higher your potential risk of heart attack. I think it's said in the next 10 years.
Yes.
Is that right? Okay.
Yeah.
So let's go over kind of the scoring system, if you will.
Sure. So, there's the degree of calcification. The calcification is not normal, and a lot of times the question I get is, does that mean I'm having too much ice cream or too much milk? It could be because you're having too much ice cream, but it's not because of dairy consumption. It's not because you're eating too many foods that have calcium in it.
Right.
The way plaque, when it heals in the coronary arteries, the plaque deposits inside the artery wall. And once that plaque is full of cholesterol and cells, and once that plaque matures and heals, it tends to attract calcium and it becomes secondarily calcified. So when you do a calcium score, you're really measuring how much plaque at minimum do you have in your coronary vessels in total, in each artery and then total. We know that underestimates the actual amount of plaque because you can't see the soft plaque, the ones that have not calcified yet. But at least it gives you a very good idea quantitatively of, do I have no plaque that's in my arteries, at least detectable calcified plaque? Do I have mild amount, moderate amount, severe, and then I even take one out and say, extensive when it gets over 1,000.
Okay, so I'm looking at a kind of a chart here on UH's page. So there's a 0 calcium score, which is less than 1% 10-year risk for heart attack, so your risk interpretation is very low. 1 to 99 is 4% risk, low. 100 to 399, 13% moderate, and 400 or greater, 24% or high. And I don't want to put you on the spot. Usually, would you then take these scores and talk to your primary care physician or your cardiologist to figure out, okay, well, what do we do next with these scores?
Oh, absolutely. I mean, I think you have to look at this 10-year risk that you get from a calcium score is the most accurate way to determine that 10-year risk. Previous to the widespread use of coronary calcium scoring, a lot of practitioners would do what's called a Framingham risk score. And based on the studies that were done decades ago in Framingham, Massachusetts, we have learned what risk factors can lead to heart disease. And so you can punch that into your phone and you can figure, and it'll calculate, this is your 10-year risk based on things like smoking and blood pressure and cholesterol. That has been shown to not be as accurate as this. And so what's particularly valuable here is that if you are a 0 calcium score, that is the lowest predictable risk you can ever calculate. There's no Framingham score that's going to come out that low where it's essentially a less than 1% risk of a heart attack over 10 years. So a score of 0 may mean, the cholesterol is a little high, but gosh, the risk is so small that there may not be a benefit of going on medication for cholesterol. It doesn't mean you still don't want to do all the lifestyle things to stay healthy. But a 0 score is clearly one extreme where if you're there, you're really in good shape. And then, you've got the middle range values. So 1 to 99 is considered low. again, I think 1 to 99 patients, depending on their age and what their risk factor profile looks like. Some of them you may put on cholesterol medication. And certainly if you're 40 years old and you've got plaque at all, we would want to, go ahead and think about treating that patient. If you're much older and you got a score of 50, we might be pretty happy about that.
Sure.
But it's a low score. Then up at 100 to 399, now you're talking about definite moderate risk, because then you've really jumped from 4% 10-year risk to now you're in the teens of 10-year risk. And it's no longer, something that is that hypothetical. Now we're looking at a 1 in about 6 chance that you could have a heart attack within the next 10 years. Well, if you're 40 or 50 years old and you've got a score in that range, that is definitely in a time frame that you are likely going to be around for. And so we can cut that risk. Those patients really should be treated with a statin drug to lower cholesterol, likely with aspirin at low dose, and the other things that need to be treated if they're diabetic, if they have high blood pressure, if they need to lose weight, they should all be exercising. The 400 or greater risk, now we're talking about a 1 in 4 chance within 10 years of having a heart attack. So these are high risk patients, and they clearly deserve aggressive risk factor reduction, again with aspirin, cholesterol medication, and then real aggressive attempts at lifestyle changes. And then we will see them above that. I mean, we will see scores not infrequently above 1,000, 2,000, 3,000. These scores are not only associated with an excessive 10-year risk of heart attack, but also a significantly increased risk of dying in a 15-year span. And so, again, the higher that score, the more aggressive we're going to tend to be.
Will you go to catheterization, or you obviously you don't want somebody to say, great, I have 1,000, I have 1,000 score. I'm going to wait for 10 years and see if I'm going to have a heart attack in the next 10 years.
Well, the majority of patients who have extensive plaque they're going to have blockages.
Sure.
Probably, all of them are going to have some degree of blockage. The question of, do they have a severe obstruction in one of their major coronaries? Usually in the absence of any warning symptoms like chest discomfort or shortness of breath that's unexplained, usually can be picked up on a stress test. So these patients who have high coronary calcium scores, generally the recommendation is, even if they have no warning symptoms, is to do a stress test, make sure that there is normal blood flow getting to the heart muscle. And catheterization generally is going to be reserved from those patients with high calcium scores that have symptoms or that have significantly abnormal stress testing, suggesting that they may be sitting on a real problem even if they don't feel it.
Sure. So again, this is all to be used in conjunction with other testing, other tools that you have. This is basically a tool in your toolbox.
It's a tool in the toolbox, and not every calcium score necessarily leads to more tests. Sometimes it just may lead to the right lifestyle changes. Sometimes it may lead to an important decision where a patient may be hesitant to take cholesterol medication, and this might be the one thing that will convince a patient, I really need to get that cholesterol down.
Sure.
Because I already have plaque, and the one thing that is, factual and disappointing as a cardiologist in 2019 is you can't get rid of it.
Right.
So once you have that plaque set up shop in your coronaries, we can try to modify how quickly that may progress. We can stabilize it so it may be less likely to cause a heart attack with the right medications. But it's not going away.
Sure.
You can't just sort of do a washout and clean out your coronaries and get rid of that plaque. So I think it is, for a lot of patients, it really is a game changer when they learn that, geez, I had no idea I had a heart problem.
Sure.
And here I have this plaque, and going on cholesterol medication, I think, becomes a much easier decision.
Right. So we'll use myself as a case study. So after you and I were discussing this and, realizing that this is a free screening available to any patient, I told you about my situation. My primary care physician is not connected to UH, but he's been watching my cholesterol. About a year ago, I think I've shared my numbers with you. My numbers were pretty good, and then my cholesterol and LDL numbers were elevated in May. We think it's because I was eating way too many eggs daily, because I really liked eggs and thought it was great. So then I've really cut back since May. No eggs, no egg yolks, eating oatmeal. Trying to do some of these healthier things. So in conjunction with Uricare and my primary care physician, we did another blood draw, and then we said, let's go ahead and do the calcium score and let's just see. I'm 46, so I'm a little younger than the typical, but I had these risk factors.
Yes.
So in terms of the screening itself, very easy. Went into the UH Fairlawn location, didn't even have to change into a gown. They asked me if I had an underwire bra, but I didn't. So literally just laid on the CAT scan, went in. It was in and out in about 10 minutes.
Yeah.
I did have, some difficulties, and we've talked to the UH folks to make sure other people don't have issues, but because I wasn't asked for my email address at the time, and because I was a patient outside of UH, I didn't get connected to an invite to the my UH care. And so then I kind of went through some extra hoops. Also, because I'm a consumer advocate and tell people to put credit freezes on, when I tried to then go through the identification process, they didn't tell me to lift my score, and so I had to work hard to prove who I was, and literally just drove to the location to get my score.
Yeah.
So, but the good news is, even though my newest blood draw still shows some elevation, I mean, it's come down a little bit. I was 209. May of last year, 231 in June, and 224. And LDLs are the important ones, right? LDL was 105, 140, and 129. So it's starting to come down. We're kind of discussing whether or not it takes a little longer for diet. But with the zero calcium score, you and I and my PCP have discussed this. That's a good case, right?
It's a great. I mean, yes. I think that the question of should you have treated with a statin drug is a reasonable question. I mean, having an LDL in June of 140 is definitely high, and you would worry about whether or not that is or is going to cause plaque buildup. Now, with a calcium score of 0 that you know about now, I think it's very reasonable to not put medication on, and there is some adequate scientific evidence that your calcium score is 0, which portends an incredibly low risk of heart attack. That if your risk of a heart attack is as low as yours is, which is less than 1% over 10 years, that the benefit of going on prescription medication like a statin drug may not be there. And that just continuing on a heart healthy diet, maybe less eggs, and exercising regularly, is all you really need to do at this point. So it's incredibly reassuring. And with no symptoms, this would be great.
Okay. Well, and then we'll finish up with, what about retesting? So I think you and I have discussed that once you have a calcium score of 0, when do I need to test again?
It's very controversial, whether or not patients should be retested. Certainly, if the calcium score is elevated already, and say you come out with the moderate 100 to 399, you're going to be treating it the same. Whether or not, and if you check it again, we don't recommend checking for at least 5 years. And I generally don't, because if the score's up, we're treating it with a cholesterol medication, they're going to be on aspirin, they're going to be, followed. And so even if the score goes up, which it will, they all tend to go up. I don't believe I've ever seen a score go down. That's partly because plaque keeps accumulating, and partly because the plaque that's there calcifies and raises the score. And so repeating scans, you're going to get radiation. It's not a lot, but doing it unless it's going to change your treatment plan. Generally, it doesn't. So that's why I don't get serial scans. Now, if you're 0, maybe at some point down the road, whether it be 5 years or 10 years, it might be worth repeating. Particularly if the cholesterol has stayed elevated. Doing another scan at 5 or 10 years down the road just to see is it still 0. It's certainly a reasonable thing to do. But we don't recommend doing it more often than 5 years.
Okay.
Because this generally takes time to develop. So if you're 0 now, you can safely assume that if you did this next year, it's still going to be 0.
Okay. Great. Well, thank you very much for joining me. I really appreciate it.
Thank you.